Hi, I'm Pamela McCabe. I am a clinical nurse specialist, and I am also a clinical nurse researcher here at Mayo Clinic. Well, for over 25 years, I have been a nurse in cardiology. I was a staff nurse on a medical cardiology unit for about 12 years, and then I decided that I wanted to expand my nursing practice and decided to become a clinical nurse specialist. So I obtained my master's degree and have been a clinical nurse specialist in cardiology for 18 years. It was during that time as a clinical nurse specialist and working with patients in cardiology that I realized there was a segment of our cardiac patient population that was not getting the attention that I thought they deserved from nurses. There was a great deal of knowledge in terms of the condition of atrial fibrillation in terms of its pathophysiology and lots of treatments, but there was very little knowledge about how did patients respond to atrial fibrillation, what was it like to live with atrial fibrillation, and what was it like to be treated for atrial fibrillation. And as I worked with patients, I realized there was a story out there to be told that had not really been formally addressed in the literature. And I realized that in order to generate knowledge about this population and their needs, I needed to expand my skills and my education and in order to do that research. And so I enrolled in a PhD program at the University of Nebraska, and with a very specific intent of studying the cognitive, behavioral, and emotional responses of patients to atrial fibrillation. My first work was really studying the quality of life, if you will, or the experience of having atrial fibrillation. And I did this by interviewing patients who had had a long-term chronic atrial fibrillation and who were seeking advanced therapies for atrial fibrillation. And by that study, I learned a lot more about what it was like to live with atrial fibrillation, the trials and tribulations that they had, the interactions they had with their providers, and their hopes for actually being cured of atrial fibrillation. That then led to my dissertation, which was a study in looking at illness perceptions and coping and its relationship to outcomes such as symptomatology and psychological distress. As I finished my doctoral program, I realized that there were some other elements of care for atrial fibrillation patients that may need some greater attention, particularly the public health implications for having atrial fibrillation and its consequences in terms of stroke and its relationship to heart failure. And as I worked with patients with atrial fibrillation and I learned more about their stories, I learned that oftentimes they did not seek help right away when they had symptoms of atrial fibrillation. And it was very distressing to find a patient who had stroked because they had not understood the symptoms of atrial fibrillation and had not sought help for those symptoms. And so I decided to turn my research career into looking at the phenomenon of treatment seeking for symptoms of atrial fibrillation. And that has led me to my current program of research. We just finished a grant in which we identified patients' beliefs that related to a treatment-seeking delay and looking specifically for factors that increase the likelihood that patients would delay seeking treatment for their symptoms of atrial fibrillation. I think there are several of my studies that have some implications for practice. One of my earlier studies was related to patients' knowledge about atrial fibrillation and their response to education that they received in the hospital. We suspected that because of the patient's time limitation in the hospital, that the education we provided to them may not be retained well after their discharge. So with a research team which included staff nurses and another clinical nurse specialist, we interviewed about 200 patients who had recently detected atrial fibrillation and surveyed their knowledge about the content that they had supposedly received when they were hospitalized about their atrial fibrillation. And we found that, as indeed we had expected, that there was a lot of knowledge deficit left. And as we looked into it and we questioned patients about the education that we provided in the hospital, we found that the educational content of what we were delivering in the hospital was just too much for them. The pamphlet was about 30 pages too long, and so we thought we need to have something simpler. So a group of us met with our patient education coordinator and one of our electrophysiologists, Dr. Tom Munger, and developed what we call now as the self-care plan for atrial fibrillation, which is just a 2-page summary of what the patient needs to know to take care of themselves in regard to managing their care with atrial fibrillation. It doesn't go into the physiology or the anatomy or anything like that. One of the big factors that we found that patients were lacking in knowledge of was the risk for stroke and what to do if they had signs or symptoms of stroke. And so that's included in the content of this self-care plan. We did a little bit of an evaluation of that after we had initiated it. We found that patients liked it. It helped to clarify what they needed to do in response to their symptoms, and the nurses love it because it's very short, it's very succinct, and it's being used all over the institution now to treat patients with to teach patients with atrial fibrillation. Another aspect, I think, of my research has been the recognition of nurses for the quality of life consequences for patients with atrial fibrillation and the emotional impact atrial fibrillation has on patients' lives. I teach a class to progressive care nurses about atrial fibrillation, and when I do, I talk about that quality of life consequence. And as I work with nurses, I encourage them not to think of atrial fibrillation as a benign illness, but one that has significant impact on patients' lives. And just because they're up and walking around doesn't mean that this is not a stressful illness for them. I have had multiple calls from authors in various countries for our work, this coming from this very interview qualitative study that we did, talking with me about how they can replicate a study. I've had a patient advocate who is in charge of a patient website quote my work. She has called me, we've talked about how on target this particular study was. So I really feel that we have made some impact. There's a lot left to do. I go back to the fact that I was motivated to become a researcher because of what I saw in the clinical setting, that we lack knowledge about the patient's cognitive, behavioral, and emotional response to their atrial fibrillation. Currently, there are very few nurse researchers who have an interest in this, so I feel like sometimes I'm taking this on by myself. I'm hoping more nurses are going to be involved. But I see myself as someone, I hope, who is trying to improve the quality of life for these patients. Patients will say to me when I've called them for various research projects and interviews, thank you for doing this. No one has ever asked me about this before. I've gotten a lot of positive feedback from patients. I find that anytime I've initiated a study, patients have been more than willing to participate because this is not something, they realize that this is something that we need more knowledge about. And so I view it as sort of a calling in a way to generate this knowledge, which I hope will then be transitioned to better care for patients.